Hello everyone, welcome to Unacademy. Let's crack NEET PG. I'm Dr. Shilpa Dinesh. I'm a practicing pediatric consultant and an educator in Unacademy. I have an experience of teaching undergraduate and postgraduate medical students, and I have done my MBBS and MD from Rajiv Gandhi University of Health Sciences. So today we're going to have a pediatric quiz, which is going to involve the various one second. Yeah, so the various chapters, so it could be any of the chapters. So I've included neonatology, infectious disease, general pediatrics, so the various other questions have been involved. So today we'll have around 80 to 90 questions, 80 to 85 questions to be discussed. So let's see how much we can finish today. So before that, I would want to talk a little bit about Unacademy. Unacademy is India's largest online learning platform, and there are a lot of benefits you can avail from this platform. Firstly, the daily life classes. So there are regular classes happening in this platform, and there are various educators teaching. So you can attend your favorite educator's class, engage in discussion, ask your doubts, and all these doubts will be immediately answered in the live chat box. Next, coming to the structured course. So whenever you're preparing for your entrance exam, you need to have a structured approach. You need to plan really well. So by the time you give your exams, you would have revised very well, right? So here in Unacademy, all our courses are structured in line with your exam syllabus, and that is going to be a huge boost for your preparation. Next, coming to live tests and quizzes. So whenever you're preparing for your entrance exam, you need to evaluate yourself. You need to know what are your strong areas, what are your weak areas, and that is possible only if you attend as many live tests, as many tests and quizzes as possible. So here in Unacademy, there are regular tests and quizzes happening, and this will help you to have a detailed analysis on your performance, and also it will help you to evaluate yourself well. Next, coming to the unlimited access. So once you subscribe to the subscription, you get unlimited access to all the classes. That is exclusive to the subscription platform, right? So even if you have missed a live class, you can go back and watch the recorded classes again and again, all in the comfort of your home, in the comfort of your own device. So I highly recommend this platform, and using this platform from the beginning part of your preparation will take you a long way. Next, coming to these are the top educators in the platform, and they have regular classes. You can attend their classes as well. Next, coming to the courses which are offered. So all the 19 subjects which are required for your NEET preparation are taught. And also, if you go and check the Unacademy app, you can see that there are various courses like the batch course, the foundation course, and the crash course. So these are all compact courses of various subjects. You can go attend those classes, and whichever you've been learning, so you can attend those classes. Okay. Next, coming to the NEET PG subscription package. So as you can see, the NEET PG subscription package varies from 1 month to 2 years. I would highly suggest the 1 year or the 2 year subscription because it is very reasonable and economical. And for the students who are giving the NEET PG 2021, for them the 6 month subscription should suffice. Okay, so the 6 month subscription costs you 20,000, and using my code Shilpa10, you get a 10% discount, and it will come up to 18,000. While the 1 year or the 2 year subscription, especially for the students who are in their third year, final year, or in the internship, do not have that much time to attend these classes all day, right? You have your hospital work, your clinics, and all that. So for them, this is the best, and also this NEET PG is a year-long preparation, so this will help you a lot in that way. Okay. So the 1 year subscription costs you 25,000, and using my code Shilpa10, you get a 10% discount, and it will come up to 22,500. While the 2 year subscription costs you 30,000, and using my code Shilpa10, you get a 10% discount, and it will come up to 27,000. Okay, so the prices are very reasonable. You just have to subscribe to the subscription and get access to all the classes. That is the only, just a click away, and I would highly recommend it. Okay, so now without further ado, we'll go for today's class. So today's questions is a mix of all chapters. So we'll start with today's first question. So tell me, what is the normal finding in the newborn? So out of all this, what is the normal finding in the newborn? Length of 30 centimeters, peripheral cyanosis, central cyanosis, or extension of the body? Tell me, what is the normal finding in the newborn out of this? Tell me. Yes, very good, Sumitra. So the answer is Peripheral cyanosis. So tell me, what is the length of a newborn at birth? What should be the length of the newborn at birth? Yes, very good. Acrocyanosis. Acrocyanosis. Okay, what is the length of the newborn at birth? Yes. So the length of the newborn at birth is 50 centimeters. So you have to 50 centimeters. So you're very right. So the answer is peripheral cyanosis. That is the normal finding in the newborn. Very good, Sumitra. Next. Newborn can have which of the following? Melia, Mongolian spot, Epstein pearl, or all of the above? Newborn can have which of the following? Melia, Mongolian spot. Yes, exactly. Central cyanosis is pathological. Fine. Now coming to newborn can have which of the following? Melia, Mongolian spot, Epstein pearl, or all of the above? Yes, very good. So the answer is all of the above. So melia is these small whitish speckles which you see especially in the nasal region. So that is normal. Mongolian spots are the bluish patches which you see in the child. So that disappears by 1 year of age. And Epstein pearl is what? What is Epstein pearl? What is Epstein pearl? So basically, it is an inclusion cyst which is seen at the in the hard palate. So that has no clinical significance. Okay. So fine. Next question. The appropriate approach to a neonate presenting with vaginal bleeding on day 4 of life is. Appropriate approach to a neonate presenting with vaginal bleeding on day 4 of life is administration of vitamin K, investigation of a bleeding disorder, no specific therapy, or administration of 10 mg per kg of fresh frozen plasma. So the appropriate approach, tell me, the appropriate approach. Okay, so no specific therapy is needed. So very good, Sumitra. No specific therapy is needed because this vaginal bleeding in a newborn is a maternal hormonal effect. It's a maternal hormonal effect. So small amount of bleed is normal. Maternal hormonal effect. Okay, very good. Next, common spot of for Mongolian spot is, what is the common spot for Mongolian spot? Is it the face, lumbosacral area, neck, or the hand? Common spot for Mongolian spot. Common area or for Mongolian spot is the face, lumbosacral area, the neck, or the hand. Yes, very good. So the answer is lumbosacral area. Very good. Fine. The next thing. Low birth weight is defined as weight at birth of less than 2.5 kg, less than 2 kg, less than 1.5 kg, or less than 1 kg. Low birth weight is defined as birth weight of less than 2.5 kg, or less than 2 kg. Okay. So the answer is, tell me. So low birth weight is defined as weight at birth. So very good. So the answer is less than 2.5 kg. So low birth weight is less than 2.5 kg. So now tell me, what is very low birth weight? 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 Yes, very low birth weight is less than 1.5 kg. And what is extremely low birth weight? What is extremely low birth weight? Yes, extremely low birth weight is less than 1 kg. Very good. Fine. So then we'll go to the next question. All of, okay, all are true. All are true about term infants except, all are true about term infants except sole crease present over the entire sole, abundant lanugo hair, breast nodule of 5 to 10 millimeter, or all are true. So, what is not true in this? Okay, we are talking about a term infant. So, what could be the best answer out of this? Yes, very good. So the answer is abundant lanugo. So lanugo is this hair which is present in a fetus. So as the child is more premature, the lanugo hair will be in a preterm baby. Yes, so in a preterm child. Okay, so the involving the entire sole, the sole crease present in the entire sole is in a term baby, while in the anterior 1/3 only is a feature of preterm baby. Okay, so fine. Next question. In asymmetrical IUGR, which organ is not affected? In asymmetrical IUGR, which organ is not affected? So we are talking about asymmetrical IUGR. Asymmetrical IUGR, which organ is not affected? Very good. So very good. So the answer is brain. So in asymmetrical IUGR, the brain is spared. The head is spared. So basically, what does symmetrical IUGR mean? The entire body has been affected. Okay, the brain and everything, there is growth retardation or growth restriction. While the brain in asymmetrical IUGR is spared. Okay, the head is spared. Yes, yes, very good. So the answer is asymmetrical IUGR. The ponderal index is less than 2 in asymmetrical IUGR. Very good, Sumitra. This is the question you have to know. Fine. What is the ponderal index of a child with weight of 2000 grams and height of 50 centimeter? Okay, so now you have to calculate. I hope you all know the formula. If you don't know the formula, I'll tell you after this. So what is the ponderal index of a child with the weight of 2000 grams and height of 50 centimeter? Very good. Tell me what is the formula? 1.6 is the right answer. So tell me what is the formula for ponderal index, Sumitra? Yes, Pradeep. Very good. So the ponderal index formula is weight in grams by height or length in centimeter cube into 100. Very good. So I'm very happy you'll have answered this. So this has been one of the past questions. Okay. Next. Which is not a component of Apgar score? Color of the body, muscle tone, heart rate, and respiratory rate. Which is not a component of the Apgar score? Which is not the component, not a component of the Apgar score. Yes, very good. So respiratory rate is the answer. So in the UPGAR, there is the heart rate, there is the tone, there is the color, there is the reflex, and the respiratory efforts. Okay, fine. Yes, very good. Yes, Sumitra, right. So next question. The investigation to be done in a neonate with jaundice is total bilirubin, conjugated bilirubin, unconjugated bilirubin, or total and direct bilirubin. So a child who has jaundice, which is the best investigation to test for hyperbilirubinemia? Yes, very good. So the answer is total and direct. So most of the time, the physiological jaundice is a unconjugated hyperbilirubinemia. But we need to know the direct component always, because so some of the pathological conditions will have direct hyperbilirubinemia. So a total and direct bilirubin is always the best investigation to be done for a child who has newborn who has jaundice. Fine. Unconjugated hyperbilirubinemia is seen in all of the following except unconjugated. Okay, is seen in all except physiological jaundice, Joubin-Johnson syndrome, hypothyroidism, hemolytic anemia. Unconjugated hyperbilirubinemia is seen in all of the following except. Unconjugated is seen in all except. Yes, very good. The answer is Joubin-Johnson syndrome. So tell me another syndrome which has conjugated hyperbilirubinemia. Yes, very good. So Joubin-Johnson and rotor. Rotor is direct or conjugated. Very good. Conjugated or direct. So now tell me, so Krigler-Najjar and Gilbert becomes unconjugated. So this is very important. Gilbert and Krigler-Najjar becomes unconjugated. Fine, very good. Next, true about extrahepatic biliary atresia. Okay, so what is true? Baby usually is full term, clay colored stools. Surgery, if done within 2 months of life, is better prognosis, or all of the above. True about extrahepatic biliary atresia. Is it a baby is a full term baby, clay colored stool, surgery is done within 2 months of life, has a better prognosis, or yes, very good. So all of the above. So tell me, what is the surgery done for biliary atresia? What is the name for the surgery for biliary atresia called? Yes, very good. Kasai surgery. Very good. Very good. Kasai surgery is the surgery which we do for biliary atresia. Very good. Next. Bronze baby syndrome is a side effect of phototherapy, usually due to the accumulation of, is it photoisomers, structural isomers, photooxidant products, or none of these? So bronze baby. So in phototherapy, so generally this child has a bronzing color. If child goes for a prolonged phototherapy, okay, that's called as the bronze baby syndrome. So why does it occur? The accumulation of what leads to the bronze baby syndrome? Take your time. Tell me, bronze baby syndrome, what is the side effect? Which is the side effect of phototherapy? Why does it happen? Okay, so the answer is photooxidant products. Photooxidant products. So based on the changes in the bilirubin, eventually there are photooxidant products which remain in the body, and that leads to bronze baby syndrome. So, okay, if you don't remember, fine. So the answer is photooxidant products. Now, which is the level of bilirubin? Now just see the picture. So this is a Kramer's rule, based on Kramer's rule. Now based on what is shaded. Now tell me which is the level of bilirubin based on Kramer's rule. I've seen in the picture, whichever is shaded. Shaded. So tell me how much is the bilirubin level. Yes, very good. So the over here the child has in the which includes 1 and 2. So 2 corresponds to 5 to 10, while 1 corresponds to 0 to 5. Okay, and around 3 corresponds to 10 to 12, and 14 corresponds to between 4 corresponds to around 12 to 15, and 5 corresponds to more than 15. Yeah, if palms and soles are involved. Hi Aparna, how come late today? I was wondering how come, where is Aparna? Sumitra was on time. Okay, so at the end I will go back to the questions which you have missed. Okay Aparna? Fine. So 1 is 0 to 5, 2 is between 5 to 10, and 3 is between 10 to 12, 4 is 12 to 15, and 5 is more than 15. Fine. Next. Neonatal jaundice at birth or before 24 hours is commonly due to physiological. Okay, yeah, fine. Physiological, biliary atresia, congenital hyperbilirubinemia, erythroblastosis. Neonatal jaundice at birth or before 24 hours is commonly due to, is it because physiological, biliary atresia, congenital hyperbilirubinemia, or erythroblastosis? What is the common cause to have a jaundice at birth or before? Very good. So the answer is erythroblastosis. So any RH incompatibility can cause this. So erythroblastosis. So basically, no. So do not confuse. I am saying at birth or before 24 hours. So any jaundice which happens at birth or before 24 hours is pathological. Pathological. A physiological jaundice is generally after 24 hours. Okay. So this is the erythroblastosis fetalis is the most important cause or the most common cause to have a jaundice at birth or before 24 hours. So the reason being any RH incompatibility or ABO incompatibility. Fine. Next. Okay. So which of the following is the most important photochemical reaction occurring during phototherapy? Very important step for what is the very important photochemical reaction, okay, which we need in phototherapy. Is it photoisomerization? Is it structural isomerization, photooxidation, or all are equally important? Tell me, which of the following is the most important photochemical reaction occurring during phototherapy? Very good. So the answer is structural isomerization. Okay, so basically the insoluble bilirubin is converted to a soluble form. Okay, so structural isomerization is the most important step in phototherapy. So based on that, yes, very good both of you. Next, now neonatal sepsis is said to be early onset if it occurs within how many hours? Yes, yes, very good Sumitra. Now tell me, early onset sepsis Early onset sepsis. Now, so basically neonatal sepsis, there is early onset sepsis and late onset sepsis. So to tell this is early onset sepsis, it should be within how many hours? 24 hours, 36 hours, 48 hours, or 72 hours. So tell me, neonatal sepsis is said to be early onset sepsis if it is set in within how many hours? Very good. So if the sepsis is before 72 hours, it is early onset sepsis. So less than 72 hours, from the time of birth to 72 hours is early onset sepsis. And if it is more than 72 hours, it is late onset. It is late onset. So remember this, 72 hours. Okay. So generally, no, 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 no. Do not. No 7 days. 7 days. No, we are talking about neonatal sepsis. Okay, we are talking about neonatal sepsis. And neonatal sepsis, it is less than 72 hours and is early onset. And if it is more than 72 hours, it is late onset. Do not confuse. In neonatal, they are talking about neonatal sepsis. So, do you all know any of the risk factors for early onset sepsis? Do you all know any risk factors for early onset sepsis? Do you all know any? What are the few risk factors for early onset sepsis? So, for example, PROM, PROM. Okay, prematurity is one. If the delivery area is unclean delivery area. Okay, so based on the surroundings at the time of birth, so if that is not clean, it can go to an early onset sepsis. Unclean PV examination. Okay, then yes, maternal fever is chorioamnionitis. Chorio, chorioamnionitis. Okay, so these are some of the causes of early onset sepsis. While late onset sepsis, yes, exactly. Increased number of PV examination, prolonged. The PROM is nothing but prolonged rupture of membrane. Yes, instrumental delivery, if the instruments are not clean, if the instruments are not clean, then it can cause. So that is unclean delivery area. Okay, whatever. Okay, that is that can cause. When you cut the umbilical cord, if the scissor is not clean, that also can cause early onset sepsis. Fine. So now tell me, in late onset sepsis, what could be the reason for a late onset sepsis? What could be the causes? Yes, for late onset sepsis, if the caregiver, the hands of the caregiver is not clean, that can go for late onset sepsis. Hospital cleanliness, if it's not good, that can go for community acquired infections are more in late onset sepsis. Fine. Next question. Antibodies seen in a neonate with intrauterine infection. Immunoglobulin D, immunoglobulin A, immunoglobulin M, or immunoglobulin G. Antibodies seen in a neonate with intrauterine infection. So what if one of this is present, then you'll have a clue that this child has some congenital intrauterine infection. So immunoglobulin D, A, M, or G. Yes. Yes, Aparna, right. Nosocomial infections can cause late onset sepsis. Exactly. Now tell me. Yes, very good, Aparna. So the answer is IgM. If there is IgM of a specific virus, or like rubella or cytomegalovirus, then this is the intrauterine infection. So the infection has been transferred to the baby from the mother because IgM crosses the placenta. Okay, so IgM. If IgG is present, it could be a new thing for the baby itself, not from the mother. But IgM, if there is high levels, high titers of IgM, IgM, then it is suggests intrauterine infection. Okay, it is IgM. Fine. IgA is seen in the breast milk, which is secretory IgA, which is good for the baby. IgM is the one which tells this, that the infection has been passed on to the baby through the intrauterine period. Okay, fine. So, next, peripheral chorioretinitis with cottage cheese with ketchup appearance. This is my favorite question. I've asked a lot of times. So, let's see if you all know. Peripheral chorioretinitis with cottage cheese with ketchup appearance is seen with which intrauterine infection? Cytomegaloviral infection, rubella infection, syphilis, or toxoplasmosis? Peripheral chorioretinitis with cottage. Yes, very good. So the answer is CMV. So in CMV there is peripheral chorioretinitis and there is cottage cheese with ketchup. So basically what? The retina appears pale. The retina appears pale and then there is in between there is hemorrhagic spots. So that gives the ketchup appearance. So there's a pale retina, that is cottage cheese, and on that there is hemorrhage. So that gives that ketchup appearance. Okay, so peripheral chorioretinitis with cottage cheese with ketchup appearance is seen in cytomegaloviral infection. Okay, now do you all know what is the chorioretinitis in rubella called? What is the chorioretinitis in rubella called? Yeah, so in CMV there is periventricular calcification, right? There is periventricular calcification. Yes. Now in rubella, what do you all see? What is the chorioretinitis you see in rubella? What is it called? Yes, very good. So the chorioretinitis is called as the salt and pepper chorioretinitis. Very good. Okay. So the skin lesions in CMV and rubella is called what? There are skin lesions. There are skin lesions. There are some purpura or ecchymosis, what you can say. So the C in CMV and rubella, what is it called? The skin lesion. Yes. So in toxoplasmosis, uh, if you get a MRI, what will you see is there is diffuse cerebral calcification. So exactly, Sumitra, right? There is diffuse cerebral calcification. If it is periventricular calcification, it is CMV. So now tell me, what are the skin lesions you see in CMV and rubella? What is the skin lesions you see in CMV and rubella? What is it called? So it is a small purplish mass kind of a thing, small spots. What is it called? It is called as blueberry muffin. Blueberry muffin spots. Blueberry muffin spots. Okay, so this happens because of the extramedullary hematopoiesis that is happening. So in the skin there is some purplish small mass kind of small like hemangioma there. So small spots. So that is called as the blueberry muffin spots and it is seen in CMV and rubella. That happens because of the extramedullary erythropoiesis. Yes, very good. Blueberry muffin spots. Fine. Next question. A pregnant lady had no symptoms. Yes, very good, both of you all, Sumitra and Apurna. So next question. A pregnant lady had no complaints but mild cervical lymphadenopathy in the first trimester. She was prescribed spiramycin, but she was not compliant. Baby was born with hydrocephalus and intracerebral calcification. Which of this is a likely cause? Is it rubella, cytomegalovirus, is it toxoplasmosis or herpes? Yes, very good. So the answer is toxoplasmosis. So everything in this question is pointing towards toxoplasmosis. So basically the mother was treated with spiramycin. That itself gives you a clue. Okay, next, the baby is born with hydrocephalus. So this is one of the congenital infections which presents with hydrocephalus. Rather, the other conditions like the rubella or cytomegalo, they will all present with microcephaly. But in toxoplasmosis, there is a chance of going for hydrocephalus. Some children can have microcephaly, but hydrocephalus is one of the common feature. And the intracerebral calcification. So intracerebral calcification is a feature of toxoplasmosis, while periventricular calcification is a feature of CMV. So this everything is pointing towards toxoplasmosis. So there is no question of doubt at all. Fine. Next, transplacental spread. Transplacental spread, remember, is least associated with transplacental spread is least associated with hepatitis B virus, rubella, herpes simplex virus, or HIV. Transplacental spread is least associated with least associated with. Yes. So the answer is C. Herpes simplex. So herpes. How does herpes simplex infection happen in the child, in a newborn? When does herpes simplex infection happen? During the time of delivery, the interpartum time. So if there is any genital lesions in the mother, if there is normal delivery happening, that time herpes simplex viral infection can transmit to the newborn. Okay, so genital lesions, if there is genital lesions and if the baby goes for a vaginal delivery, then it is transmitted to the baby. Rest all of these clauses, hepatitis B, rubella and HIV, all have a transplacental spread. Okay, do not confuse. It is herpes simplex. Herpes simplex is transmitted only if the mother has genital uh, genital rash, genital lesions, and that is passed on to the newborn if there is a normal vaginal delivery. So generally, if the mother has genital lesions of herpes simplex, then they go for a cesarean to avoid the infection to be transmitted to the baby. Fine. Tell me, Hutchisons Triad includes all except Hutchisons Triad includes all except interstitial keratitis, deafness, pegged central upper incisors, or periosteitis. Osteitis. Okay. Hutchison's triad includes all except interstitial keratitis, deafness, pegged central upper incisors, or periosteitis. Hutchison's triad. So once you'll answer, you all should tell me where is Hutchison's triad seen. Very good. Periosteitis. Very good. So where is Hutchison's triad seen? Where is Hutchison's triad seen? Where is it seen? Which condition? Okay, so the Hutchison's triad is seen in syphilis. Very good. It is seen in syphilis. And the triad, remember, the triad is interstitial keratitis, that is deafness, and Hutchison's teeth. So Hutchison's teeth is a pegged. The teeth is like this, pegged central incisors teeth. So that is the Hutchison's teeth. Okay, and another thing you should know, syphilis infection is the most common cause for recurrent, in terms of infections, if the mother has syphilis infection, that goes for recurrent, the most common infection to go for recurrent abortion is syphilis. Okay, so remember this. So the Hutchison's triad is seen in congenital syphilis. It's a triad of interstitial keratitis, deafness, and Hutchison's teeth. See, very good. Okay, okay, okay. Nice stages. That's a very good um, mnemonic. Okay, fine. A newborn child with respiratory distress, UPGAR score of 3 in 1 minute, has been intubated. On examination, he has cyanosis, apex beat shifted to the right side, and there is scaphoid abdomen. What is the diagnosis? Is it tracheoesophageal fistula? Is it dextrocardia? Is it diaphragmatic hernia, or is it pneumothorax? A newborn child with respiratory distress, UPGAR score of 3 in 1 minute, and has been intubated. On examination, he has diagnosis. Very good. So the answer is diaphragmatic hernia. Okay, so the first thing is that the child has been intubated. Okay, the apex is been shifted. Still you never know, it could be pneumothorax. But when they've told scaphoid abdomen, then you have to think it is diaphragmatic hernia. Scaphoid abdomen is a feature of diaphragmatic hernia. Fine. So there is no confusion here. So a child with a congenital diaphragmatic hernia, you should not be doing bag and mask ventilation. These children have to go for intubation and ventilation. Okay, bag and mask ventilation should not be done. Why? Why shouldn't we do bag and mask ventilation in a child with diaphragmatic hernia? Why you should not be doing bag and mask ventilation in a child with diaphragmatic hernia? So why it isn't done? So the air fills into the intestine, and that will compress the lung. That is why you have to intubate. You have to intubate and give. Okay, so if you are doing bag and mask, what happens? From the esophagus, from the stomach, then the air will enter the intestine, because the intestine will be in the lungs, right? In the area of the lung area, in the thorax. So now what happens when there is air entering these intestine? It will compress over the lung, and it will go for lung hypoplasia. That is why you have to directly intubate in these children. Fine, very good. Next, transient tachypnea of newborn develops in term baby by spontaneous vaginal delivery, term baby by forceps, term baby by LSCS, preterm by ventral extraction. Transient tachypnea of newborn develops in term baby by spontaneous vaginal delivery, term baby by forceps, in a term baby by LSCS, or a preterm baby with a ventral extraction. Yes, very good. So the answer is in LSCS babies. Okay, see, transient tachypnea of newborn is seen in a child with LSCS. So what happens? Why it is seen in LSCS? See, when a child goes through a normal delivery, so first what happens when the baby is in the tummy, in the womb, in the uterus? What happens? There is fluid in the lungs. So when the child goes through this normal delivery, because of the pressure through the vaginal tract, there is this fluid coming out, and the alveoli gets replaced by air. So a child who goes through a normal vaginal delivery going to a transient tachypnea of newborn is very rare. While in LSCS, there is no pressure trying to remove the fluid out of the alveoli. That is why a child going through being delivered by LSCS is a risk factor for transient tachypnea of newborn. Okay, so LSCS, remember this is a very important point to remember. So children who are delivered by LSCS have a chance of going for transient tachypnea of newborn. Fine. Next, true regarding congenital diaphragmatic hernia. More common on the right side. Vomiting occurs early. Chest X-ray is not diagnostic, and pulmonary hypoplasia is seen. True regarding congenital diaphragmatic hernia. True regarding congenital diaphragmatic hernia. More common on the right side. Vomiting occurs early. Chest X-ray is not diagnostic. No. Pulmonary hypoplasia is seen. So that is obviously this pulmonary hypoplasia is seen. Why the confusion? So it is not seen more on the right side. It is seen on the left side. Okay. The congenital diaphragmatic hernia is more seen on the left side. Why vomiting? There is no vomiting and chest x-ray is diagnostic. Okay, so obviously there is pulmonary hyperplasia. There is this intestine compressing on the lungs. So the answer is pulmonary hyperplasia. I see that is the right answer. Remember, this is very important. Congenital diaphragmatic hernia is seen on the left side more than the right side. Left side close to the heart. Just remember, it's in the heart. So whenever you see an X-ray of congenital diaphragmatic hernia, it is most of the time on the left side where the heart is there. Okay. So remember, congenital diaphragmatic hernia is more on the left side, and the answer here is pulmonary hyperplasia is seen. Fine. Okay, so now coming to Downy score. So Downy score includes all except heart rate, respiratory rate, chest retraction, breath sounds. Yes, Bogdale. Correct. Correct, Tejas. So now tell me Downy score which is not seen. Heart rate, respiratory rate, chest retraction and breath sounds. No. In Downy score, so let me see what are rest of your answers. Wait for some time. No. The answer is heart rate. Heart rate is not there. Okay. So tell me what are the, do you all know what are the components of Downy score? So there are five components. Five components. Okay. So why is Downy score done? Why is when is Downy score done? Okay, let me first ask you and then talk about the components. The answer is heart rate. That is not in the Downy score. Tell me why is Downy score done? Tell me why is Downy score done? Yeah, but why is it done? So it is to check for respiratory distress in a newborn. Respiratory distress in a newborn. Okay. So the five components are, one is respiratory rate, chest retraction, cyanosis, grunting, and breath sounds. Over. And breath sounds. Okay. Grunting. Grunting. Okay. So the total score. So well, I'll write it clearly here, nicely and neatly for you all. So 0, 1, 2. Okay, so there is respiratory rate, chest retractions, cyanosis, grunting, and breath sounds. Okay, so you don't need to remember so much. So now the total score is 10. Okay, so if the score is less than 4, if the score is less than 4, that means there is no respiratory distress. If it is between 4 to 7, there is respiratory distress. Respiratory distress. Then if it is more than 7, there is it is respiratory failure. Okay, so you do that. Next, true about neonatal apnea. Fine. Cessation of respiration for more than 20 or more than 20 seconds without bradycardia and cyanosis. In preterms, it is due to immaturity of the developing brain. Best way to detect breathing or apnea is by impedance technique or all or true. True about neonatal apnea. True about neonatal apnea. Cessation of respiration for 20 or more than 20 seconds without bradycardia and cyanosis. In yes, very good, Sumitra. The answer is all of the above. So in neonatal apnea, so either there is cessation, so there is stoppage of breath, cessation of breath for more than 20 seconds, or if it is less than 20 seconds, then if it is associated with either bradycardia or cyanosis, any of this can be taken for apnea of in the newborn. So apnea of more than 20 seconds, that time it is not necessary, it has to be associated with bradycardia or cyanosis. Anything above 20 seconds is apnea. But if it is less than 20 seconds and it is associated with bradycardia or cyanosis, then also it is apnea. Okay, so answer is all are true here. Fine. So you should know the definition of apnea in a newborn. Okay, so this is the definition. Any cessation of breath or stoppage of breath for more than 20 seconds is apnea. But if it is less than 20 seconds, then it should be associated with bradycardia or cyanosis. Fine, very good. Next, a 3.5 kg term male baby born by uncomplicated pregnancy developed respiratory distress at birth, not responding to surfactant therapy. Echo finding revealed nothing abnormal. Chest X-ray shows a ground glass appearance and culture negative. History of 1 month female, like there was a female sibling which had died before. That history is present. What is your diagnosis? Okay, very good. So Sumitra has already answered very fast. So the answer is neonatal pulmonary alveolar proteinosis. Okay. So this always there is a family history. There will be a history of a sibling death. Okay, so TAPVC cannot, because there won't be a family history. So over here there is a sibling death. So when there is a sibling death with a ground glass appearance, okay, without any other associated findings, then you have to go for neonatal pulmonary alveolar proteinosis. Okay, so that is the answer. Neonatal pulmonary alveolar atrial. So any of the three, the TAPVC, meconium aspiration or congenital syphilis, do not have any family history. But in this neonatal pulmonary alveolar proteinosis, there will be a family history. There will be a history of sibling death. Okay, fine. All of the following are features of NEC except abdominal distension, increased bowel sounds, metabolic acidosis, pneumoperitoneum. What is NEC? Necrotizing enterocolitis. So all of the following, yes, protein D deficiency. Exactly, Sumitra, right. Right. So that whatever happens, even if you give surfactant, there won't be any response. Okay. Yes, very good. Sumitra and Vasavi, it is increased bowel sounds. In fact, in NEC, there should be decreased bowel sounds. So decreased bowel sounds. Metabolic acidosis is a feature. So tell me, do you all know a triad of NEC based on the lab findings? Do you all know a triad of NEC based on lab findings? So the answer is increased bowel sound. So you have to, calmly read. Okay, do not say when you read increased bowel sound. So increased bowel sound cannot be a necrotizing enterocolitis. So basically, there is stasis. Actually the movement of the intestine is decreased. So there is decreased bowel sounds heard. Okay, now based on the triad, there is a triad for NEC based on the investigation. So if you all know, so I'll tell you all. So yeah, very good. Hyponatremia, metabolic acidosis, and thrombocytopenia. Thrombocytopenia. Okay, thrombocytopenia. So this is a triad of NEC. You all should know. Okay, so they might give all of the following are the features of NEC except. So they might give you hyponatremia, thrombocytopenia, metabolic acidosis, and leukocytopenia. Okay, so remember, so this is the triad: metabolic acidosis, hyponatremia, and thrombocytopenia. This is the triad to remember. Raised leukocyte count doesn't come in the triad. There could be a raised leukocyte count, but the triad includes thrombocytopenia. That is more closer association. Fine. Next. Yeah. Now, so there is a classification of NEC. So that is called as the modified Bell's classification. This is very important. You have to know, remember the name. Okay, so according to modified Bell's classification of NEC, pneumatosis intestinalis is seen in which stage? Stage 1, stage 2A, stage 3A, or stage 2B? Pneumatosis intestinalis. Yes, very good. So the answer is stage 2A. So in stage 2A, you see pneumatosis intestinalis. This pneumatosis intestinalis, so basically this is the intestine if you think. So basically in the wall of the intestine, there is this gas pouches which you see. Okay. So in the inside in the intestinal wall. Okay. So this is the feature. So basically over here ga- gas blebs are seen. So that is a feature, and this is pathognomic. This is pathognomic feature of NEC. This is pathognomic feature of NEC. So do you all know in which stage you see the portal gas shadow? Portal gas shadow. Yes, the portal vein gas shadow is seen in 2B, portal vein. And where is pneumoperitoneum seen? Pneumoperitoneum, portal vein gas shadow, portal vein gas shadow is seen in 2B, and in 3B you see pneumoperitoneum. These questions have come. Okay, always the question has been on pneumatosis intestinalis. They might ask on portal venous gas or pneumoperitoneum. So this modified Bell's criteria for necrotizing enterocolitis has to be studied. It's very important. They might even ask modified Bell's classification is used in which condition. So that also you should keep in mind. Okay. So remember, modified Bell's classification is a classification used for necrotizing enterocolitis. And in 2A you see pneumatosis intestinalis, and in 2B you see portal venous gas shadow, and in 3B you see pneumoperitoneum. So this pneumoperitoneum needs surgery. So most of these conditions where they're managed with fluid restriction, IV fluids and nil orally and with antibiotics. But if there is a pneumoperitoneum which is seen, then this has to go for a surgery. Fine. Next, persistent Morrows reflex at 12 weeks indicates. Persistent Morrows reflex at 12 weeks indicates. Normal child, indicator of cerebral palsy, irritable child or hungry child. Persistent Morrows reflex at 12 weeks indicates normal child, indicator of cerebral palsy, irritable child or hungry child. See, 12 weeks corresponds to which month? 12 weeks corresponds to which month? 12 weeks corresponds to 3 months, right? So, see, it's a normal child. So, Morrow's reflex is present till 3 to 4 months of age. So, this is 12 weeks, 3 to 4 months. The 12 weeks means it is a normal child. So, that is why sit and read the question very calmly. This is very important, okay? So, that is why I want you all to do one thing. Every Sunday, try to solve 300 questions. Okay, try to solve 300 questions every Sunday. Keep your time fixed because you'll have to read the question. Okay, so now here it is going to be a very short discussion. So this is different. You all have to solve questions every week, every at least once a month, once in 2 weeks at least you all have to solve questions. 300 questions, right? because it is very important, because so many times so many students who are very good, what happens is they're not able to complete the questions. Okay, so always you have to finish once all the questions till the end, and then you should be able to come back and see the tough questions which you were having doubt at. So very important, by the time you give your NEET PG, you should have, every once in 2 weeks solve question papers. Okay, so 300 questions you all have, no? So you will finish 300 questions for 3 hours and see how fast you can finish. That is very, very important. It will help to make your manage time. Okay. Yeah, so asymmetric Morrows reflex is not seen in. Asymmetric Morrows reflex is not seen in hemiparesis, fracture of the clavicle, sternocleidomastoid tumor, or brachial plexus injury. Asymmetric Morrows reflex. Asymmetric Morrows reflex is not seen in. The neonatology is a very important topic, okay? So you all have to know there is still so many questions. I have not included so many questions in this. So again on Monday I'm having this pediatric quiz, which I'll again come back with so many more newborn quiz. Now I think in next few questions all the newborn questions will be done. Yes, very good, Sumitra and Tejas. So sternocleidomastoid. So that has no relationship with the Morrows reflex. So that has to have. So in hemiparesis, yes, very good. Fracture of the clavicle, the child may not be able to move the limb. Brachial plexus injury, again the child cannot. So sternocleidomastoid. So it is present in the sternocleidomastoid muscle. It has no connection to have an asymmetric Morrows reflex. So the answer is right. Asymmetric Morrows reflex is not seen in sternocleidomastoid. Very good, all of you. Next, so now we have done with all the neonatology questions for today. There are still more neonatology questions which I will come again with on Monday. Okay. So for now we are done with neonatology. We'll go to the next. The most common complication of mumps is meningoencephalitis, bronchopneumonia, pancreatitis, or orchitis. Most common complication of mumps. I have done this quiz before, including infectious disease, but it's always better to repeat it so that you'll remember. Most common complication of mumps is. Very good, Sumitra. The answer is meningoencephalitis. Mumps is the most common cause for aseptic meningitis. Okay, so the answer is meningoencephalitis. That is the most common complication of mumps. So remember that. Fine. Very good. Very good, Tejas and Sumitra. The answer is, which of the following is the most common complication of chicken pox? Most common complication of chicken pox. Diarrhea, encephalitis, secondary bacterial infection, or pneumonia. Most common complication of mumps. Diarrhea, encephalitis, secondary bacterial infection, or pneumonia. Chicken pox. Very good. Very good, Sumitra and Tejas. The answer is secondary bacterial infection. Here, this is very important, especially in the skin and all the lesions happen, right? That can go for secondary bacterial infection. That is the most common cause of common complication of chickenpox. So remember, secondary bacterial infection. Fine. Next question. I hope you are able to appreciate this picture. The rash in the picture is seen in which infection? I'm hoping you're able to appreciate. Is it in roseola infantum, erythema infectiosum, erythema subitum, or erythema toxicum? I'm hoping you're able to appreciate the picture. So the rash in the picture is seen in which infection? What are you all seeing here? Yes. So the answer is erythema infectiosum. Erythema infectiosum is also the fifth disease. So what are you all seeing here? What are you all seeing here? What is it you all are seeing here? Yes, yes. It is fifth disease caused by the parvovirus. Very good. B19. Okay, so what are you all seeing here? What is this rash here? What you all are seeing? What is the rash you all are seeing? What is it called? In erythema infectiosum, it's got a name. So this is called as a slapped cheek appearance. So you can see there is flushing on both the cheeks. That is called the slapped cheek rash or slapped cheek appearance. Slapped cheek. Okay, so this is very important. So remember, erythema infectiosum is the fifth disease caused by parvovirus B19. So basically what happens, this affects the erythroid cells. So there will be temporary or transient aplastic anemia kind of a picture. So this is erythema infectiosum. Okay, what is roseola infantum called? What is the other name for roseola infantum? What is the other name for roseola infantum? What is the other name for roseola infantum? There are two names. Okay, one answer is already here in the options. So to confuse your output. No. So the roseola infantum is the exanthum subitum, or the sixth disease. Remember, okay? So roseola infantum is also, these are very important, okay? The fifth disease, sixth disease, are all small things. It might look very silly for you all, but that is what comes in the exam. So basically I'm always been telling you all, silly questions come because they all want you all to do well. It's not like that. There are only few questions which will be very difficult, and those are the ones which will differentiate the high rank and the lower rank. Okay, the most questions will be very simple. There are only few questions, around 20-30 questions, which will be difficult. Okay, so the answer is yeah, so roseola infantum is also called as exanthum subitum 6 disease. It is called caused by the human herpes virus 6. Okay, so remember 6th disease 6. Fine. Next, fever stops and rash begins. So this is a feature of which disease, which infection? Fever stops and then the rash begins. Is it measles, fifth fever, or roseola infantum? So fever stops, rash begins. So it is a feature of which disease? Roseola infantum. Very good, Sumita. So this is the phrase. So fever stops. So once the fever stops, only then rash begins. So in measles and all, there is nothing like that. In measles, the fever is there still. In the fourth day of the fever, the rash is there. So the fever is still there. The fever hasn't stopped. But in roseola infantum, what happens? The fever stops and the rash begins. That is the feature of roseola infantum. This is a very important question. It has been asked in the past many times. So remember, fever stops and the rash begins. It is a feature of roseola infantum. Okay, fine. Next. Okay, so the most common ophthalmic complication of diphtheria is, the most common ophthalmic complication of diphtheria is it ptosis, total ophthalmoplegia? Yes, isolated ocular palsies, ophthalmoplegia, external. So exactly, Vasavi. So the rash, in fact, the fever is still there. So the rash never, fever doesn't come down so easily in measles. So now the next question, the most common ophthalmic complication of diphtheria is ptosis, total ophthalmoplegia, isolated ocular palsies, ophthalmoplegia externa. Very good, Sumitra. So the answer is ocular palsy. So isolated ocular palsies is a ophthalmic complication of diphtheria. So tell me, what are the other neurological features? What are the other palsies which can happen? What are the other neurological complications of diphtheria? Other complications, what are they? Neurological. I'm talking about the neurological complications. Other neurological complications. Very important one, you tell me. If this is there, that means it is diphtheria only. What is it? Tell me the other neurological complications of diphtheria. Very important it is. Okay, so the other complications, yes, very good Sumitra. One is palatal palsy and peripheral neuropathy. Peripheral neuropathy. Peripheral neuropathy. Toxoplasmosis causes. Okay, fine. Yeah. So remember palatal palsy, ocular palsy, and peripheral neuropathy. So uh, in the what is it, onset, first is the palatal palsy which happens, then the ocular palsies, and finally in the around 3 to 6 weeks of the illness there is peripheral neuropathy which is happening. Okay, so remember these are the complications of diphtheria. They might ask questions on diphtheria. Okay, because still I was reading recently, there was an article where they were saying diphtheria cases are on a rise. Okay, so there might be some questions on diphtheria as well, so keep that in mind. So the complications, a very important complication is these children will go for, okay, what is a very important cardiac feature in diphtheria? Cardiac feature, what happens? What is a very important cardiac feature in diphtheria? So tell me, what is a very important cardiac feature in diphtheria? What happens? So these children can go for bradycardia and they might require pacemakers. Okay, so this severe bradycardia. So sometimes they can have a heart rate of 40. Okay, so bradycardia is very, very, very important. Remember bradycardia, myocardial arrhythmias, yes, but bradycardia is very important. Okay, remember cardiac feature in diphtheria is bradycardia. Yes, DCM and all that, but remember this. Okay, very good. So next question. In primary tuberculosis, all of the following is seen except. In primary tuberculosis, all of the following is seen except. Primary tuberculosis, all of the following are seen except. So we are talking about primary tuberculosis, all of the following are seen except. Yes, very good, Sumitra and Aparna. The answer is cavitation. So in primary tuberculosis, there is no cavitation happening, and even in children, you do not see cavitation that often. Okay, so they'll have a primary complex based on the immunity of the child. So the immunity of the child, there will be healing, there will be fibrosis and calcification. Okay, but if this progresses, if it's a progressive pulmonary disease, we'll go for cavitation. Okay, so in the primary tuberculosis, cavitation does not occur. Yeah, it's seen in the secondary tuberculosis. Very good, all of you. So the answer is cavitation. So generally, a primary tuberculosis, if the immunity is good, that will heal by fibrosis and calcification. Remember that. Next, I hope you are able to see this picture. Okay, so in which condition is this rash seen? Is it rubella, measles, varicella, or mumps? In which condition is this rash seen? Rubella, measles, varicella, or mumps? Okay, so what you can see over here, so the answer is varicella. So Aparna, listen over here. So you can see this fluid filled rashes. See over here, there is fluid filled rashes. The fluid filled rashes are a feature of varicella, that is chicken pox. So over here there are a lot of, and there is pleomorphic rash. So exactly Vasavi, you can see certain macules here. So over here there is macules. Okay, so you can see various crops of rash, so the various types of rash. So that is a very important feature of varicella. So this is a picture of varicella. In measles and rubella, you don't see this various varying types of rashes. So basically, you see this maculopapular rash, but over here you can see vesicles, you can see macules. There are various different types of rashes. So this is the feature of varicella rash. Okay, so there is no shouldn't be any confusion. So we will have you rash. I have yeah. So there are all these infections have different types of rash. So you have to know. Okay, so this is varicella, and this is a very typical rash. So this rash, can you see? So there is a rash over here, and around this vesicle there is this reddish erythema around the vesicle. So this rash is called as a dewdrop on a rose petal kind of a rash. So can you all make out, can you all appreciate? So can you all appreciate? So around the vesicle there is this reddish erythema. So that is called, so that resembles a dewdrop on a rose petal kind of a picture. So this is the rash of varicella. Fine. Next question. Rose spots are seen in which condition? Rose spots are seen in which condition? Typhoid, pertussis, diphtheria or measles? Rose spots. Rose spots. So this is not so much seen in Indian population, but it's needed to be. Okay. Rose spots are seen in which condition? Typhoid, pertussis, diphtheria or measles? Yes, very good, Aparna, Sumitra. So it is seen in typhoid. So basically, this rose spots, this erythematous pinkish reddish rash, which is seen more commonly in the fairer complexion people. So in Indians, it is not seen that well. But yes, this is a feature of typhoid. Okay, fine. Next, in which condition is the following seen? I'm hoping you are able to see this. I am not going to tell what it is right now. So once you'll answer, we will be discussing about it. So in which condition is the following seen? Is it rubella, measles, mumps or the fifth disease? Rubella, mumps, measles or the fifth disease? In which condition do you see this? What am I pointing at? Yes, very good. So all of you will have answered. So answer is measles. So what are you all seeing here? What is it you all are seeing here? What is the name of it? What is the name of it? What is it called? What is it called? What is it called? Tell no. Yes, very good. So it is called the Koplik spots. So it is the Koplik spot. So where is it seen? Koplik spot. So where is it seen? It is seen opposite the upper first and the second molars. It is seen opposite. It is seen in the buccal mucosa opposite the first and second upper molars. Okay, so that is the complex, or that is pathognomic of measles. Okay, so complex one. So now, yes, complex spots. In rubella, what spots are seen? In rubella, what spots are seen? Yes. In rubella, what spots are seen? There's a feature in the mouth. It's seen in rubella as well. So what is it? So it was a question which was asked. So I hope you all know what is the spot which is called, which is seen in rubella. It is seen in the oral cavity on the between the soft and the in soft palate. You see red spots. Okay, so if this is the soft palate, you see red spots like this. This is in rubella. So what is it? Forsheimer spot. Very good. Forsheimer spot. So Forsheimer spots are seen. So this is seen in the soft palate. You see these red spots on the soft palate. So that is the feature of Forsheimer spots, and this question has been asked in the past. Okay, so remember that. Next. Exanthum subitum is caused by, is it human herpes virus 6, parvovirus, parvomyxovirus, or Coxsackie virus? Exanthum subitum is caused by. Exanthum subitum is caused by. Human herpes virus 6, parvovirus, parvomyxovirus, or Coxsackie virus. Exanthum subitum. So I've already told you what is exanthum subitum. Yes, it is human herpes virus 6. So that is exanthum subitum is also called as the roseola infantum. So I every time tell you all. So how will you remember roseola infantum as a sixth disease, as the 6-month-old child by name Rose. Okay, so that is how I can, if it will help you all, it will be very good. So 6-month-old child by name Rose. I remember it as like that. So roseola infantum, it is caused by the human herpes virus 6. So very good. It's also called as the exanthum subitum. Very good. Next. Eyes of white in a sea of red is seen in. Okay, this is a rash they're talking about. Eyes of white in a sea of red is seen in measles, dengue, Ebola, or malaria. Eyes of white in a sea of red seen in measles, dengue, Ebola, or malaria. Very good. So the answer is dengue. So this is the feature. So basically there is, the skin is completely red. Okay, and in between you can see this hypopigmented or white spots. Okay, do not confuse. This is a very important question. Eyes of white in a sea of red is a rash which is seen in dengue. Dengue, 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 dengue. No confusion at all. Okay. Next. So drug use in the management of Crimean Congo hemorrhagic fever. So drug use in the management of Crimean Congo hemorrhagic fever, which is it? Is it oseltamivir, rimantadine, nevirapine, or ribavirin? Oseltamivir, rimantadine, nevirapine, or ribavirin. Drug use in the management of Crimean Congo hemorrhagic fever. Crimean Congo hemorrhagic fever. Think and tell me. This has been a topic in your guys, so that's why I've put this question here. No. So the answer is ribavirin. Ribavirin is the drug which is used in Crimean Congo hemorrhagic fever. Okay, no confusion. So tell me, which is oseltamivir is a drug of choice for which infection? Oseltamivir is a drug of choice or choice for which infection? Ribavirin is used for Crimean Congo hemorrhagic fever, and also in the Hanta infection, Hanta virus infection, also ribavirin is used. So now tell me, oseltamivir is a drug of choice in which infection? Oseltamivir is used for H1N1, H1N1 influenza. Okay, so that is a drug. Even rimantadine is a second line which is used for influenza. Where is nevirapine used? So nevirapine is used as a prophylaxis for children, infants born, newborns born to HIV positive mothers. Okay, so you should remember oseltamivir, rimantadine are drugs used for influenza. Nevirapine is used for prophylaxis for newborns born to HIV positive mothers, and ribavirin is a drug which is used for Crimean Congo hemorrhagic fever, and also it is used for hantaviral infections. Okay, so very good. So these you should know. Next, now very interesting. Now I hope you all know all these answers, all the mediums in which condition it is used. So culture medium for the diagnosis of pertussis. Culture medium for the diagnosis of pertussis. Is it Botted Gengo medium, bile broth medium, LJ media or the Loeffler agar. So tell me the culture medium for the diagnosis of pertussis. Pertussis. Is it Bordet Gengo medium, bile broth media, LJ media, or the Loeffler agar? Very good. I'm so happy. It is the Bordet Gengo medium. Very good. Now tell me, where is the bile broth media used? Bordet Gengo media is the answer for pertussis. It's the culture medium for the diagnosis of pertussis. Now tell me, bile broth media is used in which condition? Bile broth media is used in which condition? In which infection of which organism it is used? Bile broth media. Okay, so the bile broth is used in typhoid fever. Okay, in typhoid fever, enteric fever. LJ media, LJ media is used where? LJ media is used where? LJ media is used where? LJ, you should all know it's LJ media is used in. Where did you all disappear? Tell me now. LJ media is very important. You all know it also. It's yes, very good. In tuberculosis. Okay, for Mycobacterium tuberculosis. Okay. Next, Loeffler's agar is used where? Loeffler agar is used where? Loeffler agar. Loeffler agar is used where? Yes, Loeffler agar is used where? Yes, Loeffler agar is used in diphtheria. Okay, Loeffler agar is used in diphtheria, Corynebacterium diphtheriae. Okay, so remember, very good, very good. So, Bordet gecko is for pertussis, bile broth for typhoid, LJ medium for Mycobacterium tuberculosis, and Loeffler agar for diphtheria. Okay, fine. Next question. Oh, I've already told this, but still, let's see if you'll identify the following. Is it complex spot, Epstein pearl, Forsheimer spot, or rose spot? Yes, very good, Aparna. Corynebacterium diphtheria for Loeffler agar. Now tell me, identify the following. Is it complex spot, Epstein pearl, Forsheimer spot, or rose spot? What is the spot which you can see? I know you all know it. I hope you all are able to appreciate the pictures of what are you all seeing here. Once you'll answer, I will tell you all what to see. Yes, very good. So all of you all have answered. It is the Forsheimer spots. So basically, you can see these reddish spots on the so at the junction of the soft palate and the hard palate. Okay, so that is the feature of it's called Forsheimer spot. It is seen where? In which condition do you see? In which condition do you see? We see in rubella. We see this condition in rubella. Complex spots for measles. Epstein pearl is a normal inclusion cyst which you see in the palate, hard palate, which has no clinical significance, and rose spot is seen in typhoid fever. So I have discussed all this already. So we'll go to the next question. Now, following is seen in which condition? Congenital syphilis, congenital rubella, congenital herpes, congenital toxoplasmosis. I hope you all are able to understand or appreciate the picture. So tell me, what do you see and where do you see it? Following is seen in which condition? Is it syphilis, rubella, herpes, or toxoplasmosis? Very good. So it is seen in syphilis. So basically you can see the peg-like central incisors. So that is called the Hutchison teeth. Very good. Hutchison teeth. Okay, or tooth. So that is a feature of congenital syphilis. Okay. Which of the following best indicates the presence of rifampicin resistance in tuberculosis? So you have to tell which of the following test tells you the presence of rifampicin resistance in tuberculosis. Is it MGIT, that is a mycobacterial growth indicator tube, CBNAT, or is it quantiferon gold TB test or any spot? Tell me which is the best test that indicates the presence of rifampicin resistance in tuberculosis. Is it MGIT, that is the mycobacterial growth indicator test, CBNAT, or quantiferon gold TB test, or any spot? Very good. So the answer is CBNAT. So this is very helpful in pulmonary tuberculosis. It's very sensitive for pulmonary tuberculosis, but extra pulmonary tuberculosis is not that sensitive. So this pulmonary tuberculosis is very, and this CBNAT tells you about the resistance to rifampicin, resistance to rifampicin. It's a very important drug, very important test, and it gives you the report in few hours. Okay, so this is very important. So remember CBNAT, cartridge based nucleic acid amplification test. Okay, CBNAT is cartridge based nucleic acid amplification test. So it has high sensitivity to pulmonary tuberculosis than the extrapulmonary tuberculosis. Okay, so remember this. Next, in uncomplicated falciparum malaria, which is the drug of choice? In uncomplicated falciparum malaria, which is the drug of choice? Is it chloroquine or is it ACT, that is artemisinin combination therapy, or is it quinine or is it primaquine? In uncomplicated falciparum malaria, which is the drug of choice? Is it chloroquine or is it artemisinin combination therapy? Is it quinine or is it primaquine? Think and answer. No, the answer is artemisinin combination therapy. Always remember, whenever we are dealing with falciparum, we have to give combination therapies. Artemisinin combination therapy is best opted for the management of uncomplicated falciparum malaria. Tell me, where is chloroquine used? So when is chloroquine used? Do not confuse. Always falciparum malaria, it is by combination therapy. Okay, it is artemisinin combination therapy, like the artemether, artesunate, arteether. They either combine with lumefantrine. So one of the combinations they do. So now tell me, in which malaria do you give chloroquine? Which malaria do you give chloroquine? So you will give chloroquine for uncomplicated Vivax malaria. Uncomplicated Vivax malaria, we go for chloroquine. Okay, no confusion here. Uncomplicated falciparum malaria, it is ACT, that is artemisinin combination therapy. In case of complicated malaria, when there is complicated Vivax or complicated falciparum, there is no differentiation between the two treatments. It is the same. But when it is uncomplicated falciparum malaria, you prefer artemisinin combination therapy, and for uncomplicated Vivax, it is chloroquine. So chloroquine is never used for falciparum unless there is a sensitivity to it. Very rarely it is used. Now it is always artemisinin combination therapy. So remember this, these are the drug of choice for uncomplicated falciparum malaria and Vivax. Okay, we give primaquine. So in Vivax malaria, you give 14 days therapy of primaquine. But why in falciparum you give a single gametocidal dose for falciparum malaria. Falciparum malaria. So So it is given so that it has the gametocidal effect. So in Vivax you give for 14 days, while for falciparum malaria you give a single dose. Once the therapy for falciparum malaria is over, you give a single dose of primaquine in order to have a gametocidal effect and prevent community spread. Okay, fine. Next, teratogenic effect of Zika viral infection is absence of limbs, microcephaly, hydrocephalus, or optic atrophy. Teratogenic effects. So I know this, all of you all know. It was a big thing, right? So it was being told a lot. So teratogenic effect of Zika viral infection is absence of limbs, microcephaly, hydrocephalus, or optic atrophy. Teratogenic. So what is teratogenic? So if yes, very good, Aparna. So the answer is microcephaly. So this Zika viral infection, very important is the microcephaly. So it has so if the mother who is pregnant has a Zika viral infection, that can cause microcephaly in the child. Okay, so remember the teratogenic effect is very good, Sumitra. The answer is microcephaly. Fine. Next. So these are all topics which have been which have been discussed in your OP guide. That is why I've discussed here, because OP guide has told means these topics are very important. Okay, so in Nelson there is everything there, but OP guide always puts the very important topics there. Fine. Chandipura viral infection occurs due to the bite of infected sandflies, infected Anopheles mosquito, infected trombiculid mite, or infected ticks. So tell me, Chandipura viral infection occurs due to the bite of infected sandflies, infected Anopheles mosquito, infected trombiculid mite, or infected ticks. No, the answer is sand flies. So infected sand flies. So Chandipura viral infection. Okay, so basically this village is in Maharashtra. It's in Maharashtra. Okay, so it occurs because of the infected sand flies. So tell me another infection which is caused by the bite of sand flies. Tell me another infection which is caused by the bite of sand flies. Another infection which is caused by sand flies. So it is the leishmaniasis or the Kala Azar. Okay, so even there the infection is spread by the bite of infected sandflies. So Chandipura viral infection happens because of the sandflies. Next, cold antibody mediated immune hemolytic anemia is seen which infection? Aspergillosis, mycoplasma, rickettsial infection, mucormycosis. This is somehow my favorite question. So let's see. Cold antibody mediated immune hemolytic anemia is seen in which infection? Aspergillosis, mycoplasma, rickettsial infection, or mucormycosis. Cold. So an infection can cause a cold antibody mediated hemolytic anemia. Which infection is it? Yes, very good. Vastavi, Deepak, Deepesh. The answer is mycoplasma. So this mycoplasma, even chlamydia for that matter, they can cause this cold antibody mediated immune hemolytic anemia. So remember, it is mycoplasma here. Fine. So the answer is that is one of the complication of mycoplasma infection. So the answer is mycoplasma. Fine. The next question. So I have around 20 minutes. So I'll whatever how many other questions I can, I will try to finish in the next 20 minutes. Don't worry, we will have another class on Monday. We'll have a quiz only. So we'll have whatever how much ever questions I can in pediatrics, I will try to cover. Okay. So fine. Infant quadruples weight at dash months. So calmly please read it. Infant quadruples weight at dash months. Quadruples. 6 months, 12 months, 18 months, or 24 months? Quadruples. At which month? Yes, exactly, Deepesh. Very good. Cold is IgM, warm is IgG. Fine. So infant quadruples wait at how many months? 6 months, 12 months, 18 months, 24 months. Very good. So the answer is 24 months. So at 24 months, the weight is quadruple. At 12 months, what happens? In 12 months, what happens? At 12 months, what happens? At 12 months, the weight, what happens? What happens to the weight? Is it at 12 months? It is. Yes, exactly, Vasavi. It triples by 12 months and doubles by 5 to 6 months. Okay, 5 to 6 months it doubles, at 12 months it triples, and at 24 months it quadruples. So 6 months, half a year it doubles, 1 year it triples, 2 year it is quadruples. Very good. So next question. Decreased upper to lower limb ratio is seen in all except. Decreased upper to lower limb ratio is seen in all except Klinefelter disease, Turner syndrome, Marfan syndrome, or homocystinuria. Decreased upper to the lower limb ratio is seen in all except Klinefelter syndrome, Turner syndrome, Marfan syndrome, or homocystinuria. Very good. So the very good, Karki. So the answer is Turner syndrome. Okay. So over here in Turner syndrome, it has a shorter upper body. So as a result, it will be increased upper to lower ratio. While in Klinefelter syndrome, yes. So Klinefelter, Marfans, and all that, they have a sorry, in Turnus there is a longer upper body ratio, while in Klinefelter's, Marfans, and Homocysteine they have a long leg and all that. So that is why there is decreased upper to lower limb ratio. While in Turner syndrome, it's the upper body is longer than the lower body. Fine. Next, when does the head circumference and the chest circumference equalize? Okay, is it 6 months, 12 months, 18 months, or 24 months? So when does the head circumference and the chest circumference equalize? 6, 12, 18, or 24 months? Very good, Sumitra. So the answer is 12 months. So a child is born with the head circumference greater than the chest circumference. So at birth, head circumference is greater than the chest circumference. At 1 year, the head circumference equalizes chest circumference. More than 1 year, the chest circumference becomes more than the head circumference. The answer is at 1 year. So at 1 year, the head circumference and the chest circumference equalizes. Very simple question. Okay, fine. 80% of the brain growth is attained by 1 year, 2 year, 5 years, or 10 years. So 80% of the brain growth is attained by 1 year, 2 year, 5 years, or 10 years. Very good. So the answer is 2 years. Yes, Aparna and Chitra. The answer is 2 years. So the maximum brain development happens in the first 2 years of life. Okay. So the answer is 2 years. So 80% of the brain growth happens in the first 2 years. Next, windswept deformity is seen in curvy, rickets, achondroplasia, or osteoporosis. So windswept deformity. So what is windswept deformity and where is it seen? So windswept deformity is seen in curvy, rickets, or achondroplasia, or in osteoporosis. Windswept deformity is seen in curvy or rickets, Yes, very good, Sumitra. So windswept defect is seen in deformity is seen in rickets. So basically, the if this is the knee, these are two knees, so they will be in one side. So there will be it like a windswept. Okay, so this is the windswept deformity. While yes, both valgus and varus is there. So what is this? What is this? This is varus. So what I say, the R is for run away. So it is away. The knees are away. While this is valgus. So what is this is G. Get together. This is how I remember. So varus, the R is for run away, while the G for valgus is get together. So knock knees are valgus. Okay. If it is away, it is varus. But if both valgus and the varus is present, it is windswept. Okay. Fine. Very good, Deepesh. Very good, Vasuvi. Fine. Next. Kwashiorkor is diagnosed with. So there is a triad for kwashiorkor. So now tell me, what is this triad? Is it hypopigmentation, anemia or edema? Or is it growth retardation, mental changes or edema? Or is it mental changes, anemia or hypopigmentation? Or is it growth retardation, edema or hypopigmentation? So tell me, kwashiorkor is diagnosed with hypopigmentation, anemia, edema, growth retardation, mental changes, edema, mental changes, anemia, hypopigmentation, growth retardation. Okay, let's see if all of you are right. I will tell. Okay. So Mitra change the answer. Okay, so it is B. Okay, so it is growth retardation, mental changes, and edema. Okay, fine, edema, right? So it is growth retardation. So edema so will be there. You all know kwashiorkor babies have a sugar baby appearance. They look plumpy and all. Edema is because of that. So edema is very there. But these children are not active like the marasmic children. They are very lethargic and they have mental changes. Okay. So mental changes, growth retardation and edema are a triad of kwashiorkor. Okay. So remember, this is very important question. Okay, so these children are also called as, they have the sugar baby appearance. Okay, because of the edema, they look plumpy. Okay, but they do not have a very good appetite. They do not eat well. While in a marasmus child has a voracious appetite. Child who eats a lot. Okay, fine. So now identify the spotter where I'm showing the arrow. I hope you all are able to see the arrow. There's a yellow color arrow which is pointed, or I will put another arrow here. Okay, so now tell me, what is it? Is it brachytic rosary, so scorbutic rosary, Harrison sulcus, or pectus excavatum? Identify the spotter: rachitic rosary, scorbutic rosary, Harrison sulcus, or pectus excavatum. Very good. It is Harrison sulcus. So basically, you see at the diaphragmatic and the intercostal at the costal margin and the diaphragm. So basically, when the bones are very soft in the rickets and the diaphragm tries to pull the bones down, and that is why, since it is soft, it will bend and there will be a sulcus kind of a picture. So Harrison sulcus, okay, is a feature of rickets. So the soft bones which are pulled by the diaphragm gives that sulcus picture. So if there is this deep groove in that area. Okay, so that is Harrison sulcus. Very good, everyone. Next, okay, which of the following is not a mitochondrial disease? Leber hereditary optic neuropathy, NAR, MRF, or cardiofasciocutaneous syndrome. Which of the following is not a mitochondrial? Not a mitochondrial. Very good. So the answer is cardiofasciocutaneous syndrome. Okay, so I have a slide. In the next slide, I've written about some of the common. Yes. No, the answer is cardiofaciocutaneous syndrome. That is not a part of the mitochondrial disorders. Okay. So these are the various mitochondrial disorders. Just remember the name. So one is Leber hereditary optic neuropathy. One is NARP or the Leigh disease. So NARP means what? Neuropathy, ataxia, retinitis pigmentosa. Okay. Retinitis, so NARP is that. So neuropathy, ataxia, retinitis pigmentosa. Along with it, there is developmental delay in lactic acidemia. MELAS. So MELAS is what? Mitochondrial encephalomyopathies, lactic acidosis, and stroke-like episodes. Next is MRF. There is myoclonic epilepsy, ragged red fibers, and there is ataxia and sensorineural deafness. Then there is chronic progressive external, that is external ophthalmoplegia. So there is basically progressive weakness of the extraocular muscles. Then Pearson syndrome. So I always ask you about Pearson syndrome. So it's very important. So you should remember Pearson syndrome is a mitochondrial disorder, and P for P, remember, for pancreatic insufficiency. So remember that. And there is pancytopenia as well. So this is a very important. And tell me which is the best differential for this when it comes to aplastic anemia. I hope Aparna and Sumitra know this. I'm not sure if Sumitra was there during that class. So Pearson syndrome, best differential with an aplastic anemia, which I have discussed in my class. Do you all know? That also has pancreatic insufficiency. So that is the Schwarzman-Diamond syndrome. The Schwarzman-Diamond syndrome is one of the differentials for Pearson syndrome. That is a feature of aplastic anemia. That is one of the cause of hereditary aplastic anemia. So in my class of aplastic anemia I've discussed, you can go attend that class once. Okay, next is the Kern-Sayre syndrome. Over here there is progressive external ophthalmoplegia and retinal pigmentosa. Okay, so this you should remember. These are the most, the mitochondrial disorders. There are a lot of questions which keep coming. So if you remember this entire slide, it's done. I think you'll be done for all mitochondrial disorders. You don't have to think much. Fine. Next. So I have around 5 minutes. So I'll finish with this two more questions and then I'll stop the class. So we'll continue this class on Monday. Okay. Why mosaic Turner syndrome has an increased risk of? So why mosaic? So sometimes what happens, there is a Turner syndrome where they have Y chromosome as well, but it's a mosaic. Okay, so why mosaic Turner syndrome has an increased risk of developing cardiac defect, gonadoblastoma, impaired IQ, or dysmorphism? So very good, Sumitra. The answer is gonadoblastoma. Okay, so why mosaic Turner syndrome? Always we have to check for gonadoblastoma in these children. Next, a child with anti-mongolite slant, pulmonary stenosis, short stature, webbed neck, undescended testis. The most likely diagnosis is Turner syndrome, Down syndrome, Noonan syndrome, Klinefelter syndrome. Child has an anti-mongolite slant, there is pulmonary stenosis, there is short stature, there is webbed neck, there is undescended testis. The most likely diagnosis is Turner syndrome, Down syndrome, Noonan, very good, Noonan syndrome. Okay, so here, see, when you all say webbed neck, you will suddenly jump to Turner syndrome. No, how will the child have a testis? There is no scrotum. The child looks like a girl in Turner syndrome. Undescended testis is there. So it is Noonan syndrome. Okay. So tell me, what is the inheritance of Noonan syndrome? So Noonan syndrome, it is always pulmonary stenosis. The pulmonary features are more in Noonan syndrome. So now tell me, what is the inheritance of Noonan syndrome? What is the inheritance? Yes, male pattern of Turner's. See, but you know what? In Noonan, do not every time confuse. So Turner is seen in girls. Okay, Noonan, boys and girls both can be involved. So do not confuse that. Yes, it's a male pattern of Turner, but boys and girls can equally be involved. Yes, the inheritance is autosomal dominant. Okay, very good, Sumitra. So next question. The chances of having an unaffected child When both parents have achondroplasia, what is the answer? 0%, 25%, 50%, or 100%? What is the chance of having an unaffected child, unaffected baby when both parents have achondroplasia? Think properly. Make the chart in front of you all and see. See now, what is the inheritance of achondroplasia? What is the inheritance of achondroplasia? Okay, I'll come back to you, Tejas. So let's finish with this question. Tell me, what is the inheritance of achondroplasia? This is the last question. We are done, and then I'll go back to your Tejas, your question. What is the inheritance? Okay, so it is autosomal dominant. Okay, so now one gene is enough to have the defect. So just imagine the capital A is the abnormal gene and the capital B is the abnormal gene. So this is the mother, this is the father. Okay, fine. So now how? A B A B A B A B. So this is A B A B A B and AB. So over here there is no passage of transfer of the abnormal gene. So a 25% chance, yes Vasavi, so 25% chance that the child, the parents can have a unaffected baby. There is a 25% chance. So always such a question comes, always do this kind of a calculation or the chart so that it will help you, give you an idea. So there is a 25% chance of having an unaffected baby, unaffected child. Okay, so this is very important. So whenever a question comes like this, do not suddenly jump. Always check which disease are they talking about, check about the inheritance of the child and do this kind of a chart so that you will be able to tell. Okay, fine. So now coming to Tejas. So how to differentiate? So one thing is there is webbed neck, that is common for both, right? So there is a girl, it's a girl child. So very important thing is pulmonary stenosis. Pulmonary stenosis is a feature of Noonans. So pulmonary involvement of pulmonary abnormalities is for Noonans, while aortic abnormalities are features of like a bicuspid valve or aortic stenosis or coarctation of aorta are features of Turner syndrome. Okay, but don't worry Tejas, they won't give you such high-fi questions. They will just give you such simple questions. You all should be able to answer so much. Okay, but if you still want to know, so Noonan syndrome, they'll have all these pulmonary abnormalities, while the Turner syndromes will have aortic abnormalities. So they will give you some differentiating point. They won't just give you anti-mongoloid spot, short station and web neck and done. No. So they will give you some point to help you all differentiate. So that will help you all to clear. Okay, so fine. So today we have discussed, I am not going to discuss more. So we had around 10 or 15 questions left, so that I will continue on Monday. Okay, and Monday I'll add more questions. So we will try to complete nephrotic, kidney, renal disease, neurological disease. We'll try to complete as much as possible. So today we have completed this question. So Monday again we'll come with a 2-hour quiz. 2-hour quiz with general pediatrics. General pediatrics, matlab everything, anything in random pediatrics we'll talk of. Okay, so this is how it. And on Tuesday, I think we'll have a 1-hour class on endocrine quiz. So that will be done. And on Let's Crack NEET PG on the special as a special class, I will have the similar, maybe the same quiz I'll be repeating in the Unacademy platform as well. So let's see, I'll have a little mix also. So y'all will see. Okay, so I'll have a quiz in the special class somewhere between 10 to 12, I guess. I will put, oh, 12. Tomorrow is Sunday, right? 10 to 12. or mostly in the evening, 4 to 6. So let's see based on that. Tejas is a milestone class. Yes, I will do in the endocrine quiz day. I will have questions on milestones also. I'll try to do so you should be coming to my class. Only then I will know what you need. Okay, so Aparna has always been telling she needs an endocrine class. That is why the endocrine quiz is happening. So I'll do an endocrine quiz and a developmental milestone quiz, so that will help you to remember the classes topics. Okay, so that is it. So Monday we'll have another quiz on all the topics, and then on Tuesday there will be an endocrine quiz and a developmental milestone quiz, and in special class tomorrow at 4 to 6 there will be a similar quiz. Whatever, maybe today's same questions might also come. So let's see. Okay, so very important, study well, daily you all study. And I'm telling you all again, you all have to solve question papers every once in 2 weeks. Try to solve 300 questions in 3 hours, and try to know how are you able to manage time or not. So that is very, very important. Grand tests are very important. Okay, so study daily, avoid social media. And if you'll have friends, please discuss with them. If you have someone with who is preparing for NEET PG, discuss with them. And sleep early, wake up early. This will help you to remember better. So I keep telling you all this. Okay. So take care of yourself. And very important, if you are subscribing to the subscription, use my code Shilpa10 to get a 10% discount. So okay, thank you, Aparna, Tejas, Sumitra, Vasavi, and I think Deepesh has gone. Fine. So all the best. Study well. Take care. Bye. Good luck.